Thank you very much, Hugues. It's a great pleasure to be here with you, and we are a long time together working on this field. And just starting by the first slide, you know, the acute prognostic leukemia cell, and just to summarize what we have done within 40 years, I can see that where is the way to push? Oh. So in 15 seconds, you have the summarize of 40 years of work. So you can see the cell change completely from malignant cells to a normal cell, and at the end it is almost polymorphonuclear, but you can see some OR rods inside that showing that it is really the malignant cells which change in normal cell. So I start by first problem was the definition of human leukemia. It was a controversy. And just to show you an unknown person, but for me is a very important person. The name is Alfred Donné, and he was first a lawyer, and he changed, he moved to be a medical doctor. And he was passionate about microscope. And because at the time, Raspail and other people say that in microscope, the images are due to artifacts, due to the color pigments. So he was not accepted as a professor at the university. So he was at the other side of the street and gave some private lessons on microscope. He had a large audience and large attendance coming from Europe. And this person had an assistant called Léon Foucault. You know him by the gyroscope, by the pendulum. And for instance, for Alfred Donné, he manufactured, make a arc lamp in order to see them in the microscope day and night due to that. So after that, he became the president of the University of Strasbourg and Montpellier, but he was not professor. So he made some lectures, cours de microscopie, lectures on microscope, mainly on the fruits. And in this book, edited in 1844, he showed some figures of leukemia, that is leukemia without acetic acid, because acetic acid destroyed the red blood cells, and you can see better the cells. And at that time, Léon Foucault made daguerreotypes, that means the ancestor of the photography. And after that, from this daguerreotype, they copied it and engraved it on the copper surface in order to be printed. So each of them is a copper surface engraved. And he said that, in fact, in a patient that had some blood, in fact, no trace of purulent matter, neither in the vessels nor in the blood clot. Since I have frequently observed similar cases in the blood of individuals without purulent matter, I think that the excess of white blood cells is due to an arrest of differentiation. That is for the first time a definition, and a real definition, and the actual definition of the leukemia. And in this book, again, according to my theory about the origin of development of blood cells, that I have delivered several times in these lectures, the increase of white blood cells is the consequence of an arrest of differentiation of these intermediate cells. Ne sont que le résultat d'un arrêt de développement des particules intermédiaires. That means he defined completely the leukemia in 1844. But 1 year after, one of his students, John Hughes Bennett, who came back to Edinburgh, said that I saw also some cases, 2 cases of the disease with enlarged spleen in which death took place from the presence of purulent matter. So there is a dispute between them and discussion about is it purulent matter or not purulent matter. And I think that Alfred Donné saw this intermediate cell and said that it is due to the differentiation. And 4 weeks later, after John Bennett, the German Rudolf Virchow says that it is white blood, Westblut. So you see that there is some discussion about it. The second reason is we arrived at that to the differentiation through rational or serendipity. Leo Sachs was a pioneer of that, and Hugues de Thé say that it is a real person, and he inject in the mouse myeloid leukemic cells into an embryo of the mouse, and he saw some mature cells at the end in adult mouse. So it was the first time it was possible to change, but some cells, these cells are from leukemia, but it's also cell lines and cultivated. It's not really fresh cell from the mice. But he could change the cells inside the body of the mice. And after that, he found the cytokines with the name, and this Hebrew name from Israel, and he called them MG1, 2, 3, 4, and it corresponds to the GCSF, MCSF, GMCSF, and IL-3. He was a real pioneer of these growth factors and differentiation factors. He said that there are some differentiation factors, but he didn't find any. So after that, serendipity, not rational, but serendipity. I saw a person, a woman, a 50-year-old person, with acute myeloid leukemia in relapse, resistant to any chemotherapy, and infected by mycosis septicemia. So at the end of the life, I prefer that she would be at home in Brittany and to see her parents and children. And I told to the GP to give a very, very low dose chemotherapy, aracitin, morning and evening. And what happens? 3 months later, this person came back in my consultation, completely normal, with the blood normal, with the bone marrow normal. So, and the GPs tell me that it was so difficult, but every day I gave this low dose of therapy, and progressively everything disappeared. So we tested 2 other patients and found a similar pattern, and at that time we call it differentiation myeloid leukemic cells. So a small dose of RST can change the malignant cell to a normal cell. So many other inducers are possible for myeloid differentiation. For instance, after the injection of Leosax, but cytokines. For instance, the GCSF and GMCSF can differentiate completely Kazumi cell line, which is AML1E2, so 821 translocation. Chemicals like butyrate, DMSO, and a friend of me from Sardinia gave the DMSO, a very large amount of DMSO to a shepherd, because the problem of DMSO is that there is a taste of garlic taste, which is very horrible for the environment. So, and for Bolester, low-dose chemotherapy, RSC, but also other drugs like aclacinomycin, which are very good in vitro to modify the malignant cell to a normal cell. Hormones, high-dose corticosteroids. The Turkish people give the glucocorticoid high dose for the chloroma, which is a tumor with, again, the AML1E2 translocation. Vitamins, you know, retinoids, vitamin D3, histone deacetylase inhibitors, trichostatin in vitro is a very good differentiator. And valproate, which is also a good drug, and it was tested by RAFU for acute myeloid leukemia. Dimethyl agent, you know that for 5-acetylene and deoxycytidine. So there are many possibility to change the malignant cells in normal cells, mainly in vitro, but sometimes in vivo. So the problem is that we studied the retinoids, and Theodore Breitman, and as referred, Hugues de Thé, showed that there is some terminal differentiation. And Christine Chaumienne, with us, we took 60 fresh cells from patients and test and saw that there is a real differentiation of acute promyelocytic leukemia with all trans-retinoic acid. For instance, she compared the 13-6 all trans and 4-oxo. You can see at the dilution at 10-8, only all trans-retinoic acid is able to modify the malignant cell to a normal cell. At the time, we had only aromatic retinoids, Tigazon in Europe. Doesn't work at all. And in the States, they had the 13-6, but all trans was not available. So we have to find how to have this drug. And happily, at that time, Chen Shu was in our lab, in Sun Lab, and his boss, Wang Chengyi, came to visit him. And I explained that you cannot have the drug because Roche refused to make it. And he told me, and with Christine Chaumienne, told me it's possible to do that in China. So after that, the first step was to have the drug from China. So the third lesson is dogma and anti-dogma. The drugs came from China, all transmitted retinoic acid, so give to the patient. I went in China to see Wang Chengyi, and the first person in the here is I don't know if here is Wang Minghe, who was the first author of the paper in blood. He came in France, in Paris, and Rennes, and now he's in Institut Curie in France. So that's the first patient. I saw the first patient in 1987 in China, and what happens in vitro happened also in vivo. And for that, we worked together, and during a press conference, and it was a travail à deux. That means that two for this work. Wang Chengyi told that without finding in the meeting we had in 1985 with Christophe, nothing would happen possible. This study made in Hospital Saint-Louis in Paris opened my eyes about ultra-secreted acid. So it was a real collaboration between the Chinese and the French. And we made a comparison between ultra-secreted acid plus chemotherapy compared to the chemotherapy alone. You can see the big jump of the remission rate in these trials. So we published it in Blood, and they asked us to make the cover page. That's good. But the problem is the dogma at that time that it's not possible to have a reversion of the malignant cells. A malignant cell is irreversible. So the editorial made by one of the most important American hematologists was acute progressive leukemia, another pseudo-leukemia. He said that it is like the pernicious anemia with vitamin B12. So now we have another disease, is acute progressive leukemia with vitamin A. So the question is for the mentality at that time, the spirit at that time, is not possible to reverse a malignant cells. But with the Italians, we had a lot of meetings, mainly in Roma, and it was acute progressive leukemia, a curable disease. So there is dogma and anti-dogma. So the dogma is not reversible, and the anti-dogma is that it's possible to reverse it. The third lesson, the fourth lesson, is a complementarity between Western medicine and Chinese traditional medicines. So Hugues de Thé and de Jean, we showed that there is a translocation between the retinoic acid receptor, alpha, and another gene called at that time MIL, but now it's PML. And the question is, how does it work? How retinoic acid works? So it could be an enhancement of the replacement of the co-repressor to co-activator. There is very good argument for that. It could activate the destruction of retinoic acid receptor. That's a very good argument for that. And it could activate the normal, the expression of the normal receptor, because there is two chromosomes, and the normal one is normal. So the question is, how does it work at that time? And for the PML, it was shown that it is an outshell of the nuclear body described by the father of Hugues de Thé first. So it was interesting to know what happens, what that. And conversely, there is in Manchuria, Harbin, is the north of China, very cold. I have been there, it's -40. So, but in Harbin, they described. They found the arsenic as a good drug for the same disease, the acute progressive leukemia. And for a long time, it was accepted as a good drug for leukemia. So this first description provoked a collaboration between Shanghai and Harbin. And after that, the arsenic was made in Harbin but tested in Shanghai. And we saw that in France, in the textbook of the 19th century, there is a word. The treatment by arsenic is probably the best treatment for the leukemia at that time. So it's amazing that even this story of arsenic probably came from China to Europe, but Europeans took that in the textbook. And after that, Hugues de Thé and Valérie Lallemand showed that arsenic plus retic acid together eradicate the leukemic cells in mouse model. So that was a big jump to treat, and mainly due to the two types of degradation. First, by the retic acid receptor, the retic acid itself could induce ubiquitination and degradation, and through the PML moiety, the arsenic could also push this molecule, this hybrid molecule, this oncogenic molecule, to the degradation. So the fifth lesson is a cure of this drug and beyond. So Lococo, with a large trials, Italian, German, and others, showed that retic acid and arsenic could eradicate in vivo completely the disease. And Alan Burnett, 2 years after, showed also that it is possible to eradicate this disease and in all risk groups, which is very important because only two natural drugs with vitamin A and arsenic are able to change the malignant cell to a normal cell, the differentiation with a complete eradication of the disease for the life. And that is a real cure. So more recently, you know that FLT3 mutation could also be, by the anti-FLT drugs, could also induce some differentiation. Terminal myeloid differentiation in vivo induced by FLT3 inhibition. And this drug, the GTRDB, induce a differentiation in RAPS and refractory FLT3 mutated acute myeloid leukemia. So it's possible now to have other model, and you will discuss today about IDH2, also that mutated IDH2 could be a good model for the differentiation therapy in acute leukemia. So today, what we learned that not only that APL is a model for differentiation therapy, targeted and personalized medicine, or curable disease using natural product, but also it changed completely. I am a clinician. It changed completely our mentality about what we call prognostic factors. Prognostic factors reflect the ability to treat or not to treat an intrinsic cellular disorder. APL was considered, when I was young, considered as the most severe disease that killed the patient in 8 days. And today is the most good prognostic factor. If we receive a patient with an acute progressive leukemia, we're quite sure that he will be cured without very, very simple way with these two drugs. So the second lesson also is that in this disease, it works whatever are the other disorders. Other disorders are cytogenetic abnormalities, mutation. So differentiation therapy overpass any other problems of the leukemia. So that means that probably the best way to cure the patient with leukemia is to change the malignant cell to a normal cell, whatever are the other disorders. And also, I like to compare the two curable diseases, two curable leukemia today. The first, you know that it is APL with the vitamin A and arsenic. The second is chronic myeloid leukemia with a Gleevec. And when we look on the treatment of the patients, so with vitamin A and arsenic, we can have a permanent cure of the patient with a short and definitive treatment. So just one shot, we can treat the patient, and that's enough. Compared to the problem of the CML, that we are obliged to treat the patient permanently. So permanently, he has to take the Gleevec. So the question is why? Why it is one shot, and why it is permanent for the other? And probably it is an idea. I don't know if it's true or not. But when there is a degradation of PML-RARA through the proteasome, we know that at the end of the proteasome, there are the HLA molecule just waiting to take the antigens in order to present them at the surface of the cells. And why not it is due to this immunogenicity or this immune reaction after the degradation, which is important for the permanent status of the patient. So if so, that means that differential therapy should be connected with immunotherapy in order to have a better issue for the patients. So in conclusion, Alfred Donné defines the leukemia as an arrest of differentiation. I like very much his definition of Alfred Donné. Leif Isted defined the APL, acute progressive leukemia, in 1957 as the most malignant leukemia, but today APL is cured by cell modifier, so-called differentiation therapy, and using 2 natural products. The question, I think, for this seminar is, are we able to transfer the differentiation therapy to other malignancies? Thank you.